Good evening. On behalf of IIP Technical India Technical Team, I welcome you all to webinar on kinetic chain activation technique. We are live on IIP India YouTube page. You can subscribe to this channel for getting regular updates, or you can also follow us on our Facebook page. During the presentation, if any of you have any questions to the speaker, you can put it in the Q&A section. The moderator for today is Dr. Manit Dixit. He is IIP UP State Treasurer, Principal of Pacific College, Gorakhpur. We also have our IIPWC UP State Committee members, Dr. Anjana Tawatia, Joint Coordinator, and Dr. Renu Giri, Sub-Coordinator. Now I request Dr. Manit to please commence with the session.
Good evening, everyone. This is Manit Dixit, Principal Pacific College, Gorakhpur, Treasurer UPIA. On behalf of IAP UP Women's Health, under the guidance of Dr. Ruchi Vashne and Dr. Deepti Goyal ma'am, I welcome you all on the webinar that is Introduction to KCAT, organized by Dr. Shruti Sharma, Dr. Anjana Tevatia, Dr. Anshika Singh, Dr. Deepika Sharma, and Dr. Renu Giri. Friends, I have personally knowing many of the associations and rarely any of the association where I can see that General Secretary and the President himself are carrying the flag of continuous professional development. We are really the luckiest one to be a physiotherapist and to be the member of Indian Association of Physiotherapy, where our General Secretary sir himself is carrying the flag of professional development. And so if we were any lesser happy by our General Secretary and President sir, our Treasurer, Dr. Ruchi Vashne ma'am is also there. Good evening, ma'am. We welcome you all. And friends, before I can hand over mic to our General Secretary sir for the session, I would just like to give a brief info about him. Annamalai sir, currently Apollo Hospital International Head in Ahmedabad, has worked as physiotherapist for Indian cricket team squad during World Cup in 2011. He is member of Indian Physiotherapy Association, of course, and Health Professional Council of United Kingdom. He's a member of Board of Studies at Chaurasat University in Changna, Gujarat, and as ergonomist of institutions such as Indian Institute of Materials Management, ONGC, TCS, British Petroleum, Ultratech, and many more. Currently, sir is also working as Chancellor in the Gandhi Gram Rural Institute since 20th April 2017. And to know what a great clinician and academician he is, the only way is to listen to himself. Sir, may I please hand over the session to you?
Yeah, thank you, Manit, for the wonderful introduction. And I'm so happy to be here in this momentary evening that we all are locked out because of Corona. So we are just have a more opportunity to have a great insight within ourselves to re-initiate passion to education as a physiotherapist. It's a wonderful opportunity thanks to Corona because we all are able to connect beautifully with this beautiful event, because in every problem we should look for opportunity. That is always what I believe. So I think our IAP has taken this as a wonderful occasion to connect the people in the case of a professional way of knowledge sharing. So really appreciate for this opportunity provided by Team Uttar Pradesh, both the Women's Cell as well as for IAP. I'm really thankful to you both because you are doing a lot of good work since many days. I just know that you are going through a lot of people are taking webinar around the country, which actually during the rest time, I'm so proud that our physiotherapists are not going rust during rest because they all are keep on just shining our brains through Indian Association of Physiotherapists. Especially this YouTube live has been started recently by our IAP. It is doing amazing work, which is actually a lot of people are getting involved on it, and they are just using of it. And really, it has been what you can call it as eye-opening idea. And really, I would like to thanks to our treasurer as well as my honorable president that they both are taking this initiative in a beautiful way. So I'm thankful to them. And let us start my opportunity to use in a right way. Every moment I would like to give some other idea to you to think about it as a great clinician. Thank you so much. Let me start my session. Okay. So today I'm going to talk about kinetic chain activating technique, KCAT. The beauty of this technique is it is made in India technique I used to call always, and it is very close to my heart. Before going to explain about this technique, I would like to give few importance and insight of this technique. I was inspired this technique by means of Indian literatures and the indigenous way of practicing of Indian literatures. So with that inspiration, I just properly mix up the Western science, because the Western people always need evidence to understand. So I created a lot of evidence based on it. But I don't believe basically on evidence based. I believe more on evidence informed practice, which is more purposeful practice. So this KCAT is such a different technique. So I'm so happy to give orientation about it right now. Before going to that, let me talk about something about myself, how I just transform myself from cardiorespiratory to musculoskeletal. Actually, my basic education is on cardiorespiratory. I love cardiorespiratory. I'm passionate about the critical care units, and still I'm working as a critical care therapist. But how I got a transformation for a musculoskeletal, if you understand that, you can understand how the KCAT must have been evolved. So it is a technique evolved in my hospitals. That's it. In simple way, my patients are teachers and patients are books. They taught me this technique. So I'm not saying this technique is a complete technique. It is evolving technique. So still I'm just learning new and new from patients. I'm evolving. I'm contributing to my technique in a better way, because I always believe that until the end of the day of death, we should be a student, because then only we can learn a lot of things. Because before a moment of death only, we will learn what is the exact nature of death. So we are students. So I believe it strongly. So actually, before 10 years, I'm a passionate cardiorespiratory therapist. In way which I work, I see only ICU patients and the critical care patients, and ortho patients and neuro patients I refer to the therapist. I say that it's not my cup of tea, because I don't see, because I have the proud that I'm a critical care therapist. Like that, I had that mindset. Because for damn reason, you should understand that. I thought when I do work in critical care, I can give immediately changes in my naked eye on ABG, X-ray, as well as the stethoscope on auscultation. I give a big change, and as well as I can give a good changes in the case of outcome of ABG analysis, and ventilator setting will also get changed. So I thought I can able to produce more results on this. So as in musculoskeletal and neuro, I thought neuro it won't come any results, and musculoskeletal I believe that actually if you are in a forest, suppose a line is getting fractured, it is not going to any orthopedic surgeon or physiotherapist. It stays at its place for a month, so it automatically taking its rest to the nature's lab, and slowly start to walk, something like limping, and your uneven terrain act as a physiotherapist to train it, then it start to run. So I thought nature heals, what is my role? So in that sense, I was not believing that, okay, only critical care and cardiorespiratory is a great subject. So I know this is my ignorance, but the thing is, I thought of in that way before 10 years. So suddenly suddenly in my hospital, normally we do around 8 to 10 bypass per day. So what happened, I was just working in bypass unit, regularly doing my regular protocols and all those things. I see patients, challenging patients, ventilator patients, and head injury patients. All those things I used to work in critical care. So suddenly one day what happened, we have 1 or 2 patients having a shoulder problem who is post medial sternotomy. So post-median sternotomy, they have shoulder problem. I used to call my fellow colleagues to take care of that. Sometimes I will take care of it, but I can't give good result on shoulder problems because I work more on chest and lungs and congestion, and whether the patient is having a saturation drop and whether the patient functional capacity is good. All those things in my mind it is going on, so I'm not much worried about it. So what happened? Once upon a time, what happened? There is around 8 bypass patients, around 6 are having a shoulder problem or some other musculoskeletal problem. Then they asked me to look into it. So then I decided that okay, let me do something like that. So I started to do some prophylactic workout. In that one day, it was an inspiring day. I was taking a patient where the shoulder range was going only this much, and he's having a sternotomy, and the cuff muscle, the artery has been taken, the spinous vein has been taken as a graft for the patient. So what I did means, he asked, sir, can you look for my shoulder also? Yeah, I will look after, don't worry, let us first finish the chest. So I was keeping working on chest. What happened? I was giving prophylactic exercise of ankle pump exercise. So I gave ankle pump exercise. After that, I asked him to lift the hand. His hand was lifted a little more. So he was so surprised. He thought of that, wow, what is the magic you did? But actually, that time, honestly, I do not know what magic I did. But I really, being a therapist, I want to show myself, yeah, I'm great. I can do all these things. This is a magic like that I've shown later. And this incident has been sad in my mind that actually somewhere I'm doing, somewhere the results are coming. So what is the correlation, how it works? Then I thought I'm very weak in musculoskeletal, though I don't have much idea about it. So I want to just explore it. So what I started to do means I started only. I started to learn a lot of things from a lot of inspiring articles from abroad, as well as our indigenous articles. Then this KCAT got evolved. So the KCAT got evolved. So most of my techniques are evolved in ICU. So KCAT techniques more or less like a technique of critical care unit technique will be insisted in the musculoskeletal problems, and outcomes will come differently. So it is totally a different kind of now the KCAT concern, how it has got evolved. So now I'm going to talk a few things. First, before that, I would like to share my slides. Then I'll show some practical tips. So let me share with you the screen. Host disable participate screen sharing. So share the screen.
Sir, now you can share.
Yeah, I got it now.
Okay.
Thank you. Perfect. Okay. So kinetic, it is all about secret about movements. Okay. So what is KCAT? It is an interface of physics, maths, biology of movement science. So we are just working with the movement science. The KCAT is an interface of 3 subjects: physics, maths, and biology. I think this is only a mathematical model of physiotherapy subject. I think so. It is a new idea all about in this KCAT around the world. It's a mathematical model. So it's an interface of physics, maths, and biology of movement science. It consists of innovative principles, concepts, algorithm, and formulas to reshape the human movement dysfunction to normalcy. So if anybody is having a movement dysfunction, we have to bring it to normalcy. So we have to work out through this process. We have to have, I have concepts. Actually, there are 10 concepts or 10 principles we can call for KCAT. So if you know the 10 principles, then you have an algorithm and you have a formulas. So then if you apply in the formula and algorithm, you will get a diagnosis. Based on the diagnosis, you can correct the movement and movement dysfunction will become normalcy. This is all about KCAT. So KCAT is a combination of biology, physics, and movement science and maths. The KCAT workout are based on fascia science, Newtonian physics, metaphysics, evolutionary biology. These are all the 4 components of KCAT: fascia science, Newtonian physics, metaphysics, and evolutionary biology. It is very effective in patients with movement dysfunctions due to physical or emotional illness. See, actually, the beauty of KCAT is it is actually addressing both physical and emotional illness. Normally, general physiotherapy subjects are dealing with more or physical, less on emotional, but here 50% physical and 50% emotional illness can be taken care by KCAT. It is non-chemical intervention externally. There is no chemical we are using in this intervention. So that's why it is a part of physiotherapy. Okay, how the KCAT got conceived through, how I got this idea, why I start to work on this idea, conceiving. So how it has been started inside the mother's womb of KCAT. So whenever I just go to anatomy books from my college days, and I used to read a lot of anatomy books, and what happened means I learned a lot of things from anatomy and a lot of fascinating facts. But when I want to apply the anatomy, or same time I'm just reading a lot of physiology, when I apply physiology, I don't know how to apply it. I don't know how to apply anatomy, but I know anatomy, I know physiology, but I don't know how to apply it. So this was, I don't know why, what is a missing link. So that time I decided that, oh, that's good. So we are reading, or we are intervention we are doing. Suppose you take MRI, or you take CT scan, or you take X-ray, or you take any damn kind of investigations, or you just take any kind of pictures or atlas, anatomy atlas, or anything. If we go through it, all are two-dimensional pictures, whereas actually we are working on three-dimensional organs and three-dimensional tissues. Tissues are three-dimension, but we are studying from two-dimension. We are trying to apply in three-dimension. That is a missing link I found. So in the KCAT, we are developing the link between two-dimension and three-dimension working patterns. So for example, if you say, if I take a heart, if I see in two-dimension picture, I look, it's a flat organ. But it is not a flat organ, it's a 3D organ. It is having both anterior, posterior, lateral medial, and superior, inferior, as well as the rotatory component. All these components are there. But when we are just looking into CT scan, or when we look into a MRI, or when we are looking for any this thing, so mostly we look into a two-dimensional things. So basically, whatever we read in the books, our training process, all are two-dimension, but we are trying to apply in three-dimension where the failures occur. So I want to bridge the gap through this KCAT. If you take an idea of KCAT in a simple way, two-dimension and three-dimension. In two-dimension, basically, suppose, okay, the one more problem is, so mostly we are doing a functional anatomy and structural anatomy. There are two things. So if you see, if you are doing dissection also, if you are reading through dissection also, what is happening? When you are doing dissection, generally the tissues are dyed and the patient is actually lying down basically. So the autopsy is done at the dead body on lying down position. So basically in lying down position, basically the gravity is not at all acting, or elimination of gravity. So when you are just learning the organs on elimination of gravity, and you are trying to apply in the against gravity posture. So that is again a missing link, so which is connected by this KCAT activity. This is almost like throughout the year of your academic year, you are trying to learn violin, and suddenly in orchestra I am asking you to play drums. So what will you do? Same thing is happening. Two-dimension to three-dimension, and structural anatomy, we are seeing an elimination of gravity to the against gravity. So the things are totally different. And very important thing is the KCAT is conceived through embryology to gerontology. So if you know certain things about deep into embryology, so it is easy to control the entire segment of tissue until gerontology with some mathematical calculation. So that's why the KCAT is conceived through embryology to gerontology. So we have a solutions for the problems from embryology to gerontology through KCAT techniques. Next, unicellular model to multicellular evolution. So here we are just going through the evolution process. That's why I just said it's evolutionary biology. We are working on DNA level. We can work at mitochondrial level. So that's why unicellular level to multicellular level, the evolution process can be conceived through KCAT. And micro to macro movements. So here what we can do means a micro movement which is not at all noticeable. Your CSF is flowing inside. You cannot able to admire in it, and you cannot able to feel, realize or recognize it. But actually CSF is flowing inside. So the movement of CSF is the micro movement. The macro movement is your just naked eye movement of function of hand and legs. So the micro movement to macro movement, we have a stratifications and we are working based on that, and we have a different clear entities and we are just working on KCAT. And what is a great idea about all this thing means the present tense to past tense. So what is present tense means you are coming with a problem to me. So that is a present tense. So what we'll do means from the present tense, we want to understand why your present is today means because of your past tense. So here we have a time machine management to understand your past tense. And from the past tense, what we do means we will just predict the future tense, what you can going to happen. So what are the dysfunctions can happen and what are the way to stop. So what you can, it is actually covering the process of rehabilitation to prehabilitation or prehabilitation to rehabilitation. So this is all about idea about KCAT, how it is different from other subjects. Okay. So I said the KCAT is of 4 integral components. One is basically facial movement science. KCAT is a part of facial movement science. Fascia is the layer around the body, which is a packing material. It is a package material. I can say in 2 ways. It is separating the borders between the organs, and same time we can say that it is uniting the organs. So it is depends on your vision how you can see. You want to see the fascia as a packaging material, and you want to see the fascia as a separating the segments, or it is connecting the segments. You can take as you wish. I said it is a part of Newtonian physics. The Newtonian physics is called macrophysics. Macrophysics means here we are going to work. Our instruments in KCAT is inertia, gravity, and all this anti-gravity, inertia, all these things are we are going to use it as a Newtonian physics formulas to understand that. We have some formulas and algorithm. We work on that. So based on Newtonian physics. So it is a mechanical impact can be easily force, momentum, all these things we are going to take care of it. So it is a part of Newtonian physics, and it is a part of metaphysics. So metaphysics means it is going to talk something deeply into the micromolecular movement of within the cellular process. So that also we are going to work on. So KCAT is going to take part of metaphysics. That's why I said that it can take 50% of biological movement to psychological movement. That means physical to mental health, it is covered. So that's why the KCAT is a two side of the coin. It works on both sides. So it's a metaphysics as well as a Newtonian physics. And KCAT is a part of evolutionary biology. So it's a part of evolutionary biology means we are going to talk about the movement science evolution and movement from embryology to gerontology and middle age peak grade movements. All this movement has been stratified, and this is actually based on that movement requirement. We are going to design the protocols, and we are going to design the plans and mathematical formulas, and we are going to apply. So KCAT is a part of evolutionary biology. Okay, where did I inspire from? The KCAT is inspired from traditional indigenous method of movement science like Siddha, Yoga, Tirumular Tirumandaram, Rigveda, Tolkappiyam, and Marma. These are all the different books which I just got the inspiration to create this KCAT. And thanks to all of those people. And Western medicine really, the functional anatomy and structural physiology, and physics and evolutionary biology. So these are all the people who inspired me a lot to get into this shoes of KCAT. Okay, so now let us understand how the KCAT works and what level it can intervene with the KCAT. First, if you say any disuse or misuse of your tissues, I'm calling tissues, I'm not taking muscle, I'm not taking fascia, I'm not taking bone, I'm not taking any of your organs. I'm taking any tissue, any damn tissue where the cell is live and cell is good and there is a metabolism and catabolism, anabolism is happening. That is all about your any tissue. So tissue go for disuse or misuse. So disuse or misuse means if you don't use at all, that is a disuse. Misuse means awkward use, or you want to take only 10 kilos of weight, you are instead of you're taking 20 kilos of weight. So disuse or misuse results in injury. So injury means there is a microbial changes in the cells. So when the injury happens, you will automatically feeling of some emotional immobility. I don't want to move. I feel something uncomfortable. So this is a injuries make you to think that kind of immobility idea. So immobility for a long time leads to adhesion. Adhesion means a glue into the body, which is just sticking between each other. The fascias will get stick with each other. So that is all about adhesion. So once the adhesion has been taken care, so automatically that movement is getting restricted. So dysfunction happens. So dysfunction means you cannot do the function fully to an extent of full. So when the dysfunction for a long time sustained, you will reach into deformity, fixed flexion deformity of knee, and all these things are before that you have a dysfunction area. So once a deformity has happened, then slowly you are getting into the spectrum called disease. That is called osteoarthritis of knee. So disease. So once you got into the disease, then slowly you cannot able to do functionally activities of daily living and all those things. Slowly you become a depressed. So once you become depressed, further it is going for disuse and misuse. It's a vicious cycle. So this vicious cycle is called KCAT cycle. So what is the beauty of KCAT cycle means? This KCAT technique can be intervened at any protocol area. If you are between the patient of disuse and misuse and injury, we can use with KCAT. You have a different ideas. And if you have between injury and immobility, we have a KCAT. And you have immobility and adhesion, we have an intervention of different KCAT. Adhesion and dysfunction, we have a different method. Dysfunction and deformity, we have a different method. Deformity and disease, we have other method. And disease and depression, we have other method. So everywhere, all 360-degree, we can just intervention we can done with this KCAT. Okay, what are the 10 different concepts of 10 KCAT? So if you don't understand this 10 concept, you cannot apply the formula. So these are all the basic concept. So these are basically derived from physics and derived from biology and derived from their movement science. This is basically the first concept is sensory input is equal to motor output. So kitna sensory input हम देते हैं उतना motor output आएगा. Good and bad sensory, which results in good or bad movements. And there is a third part called root cause analysis. And fourth is called range of movement. I'm actually I'm just move away from the old pattern of range of motion, whereas in KCAT I call range of movement. I don't believe on range of motion, and that's the reasons are there. We have different reasons and we have evidence. And evidence informed practice. Actually, we are moving away from evidence based practice. I feel it's a little lesser importance than evidence informed practice, because which will give more money as well as make patients to understand me better, and it create a good platform or bridge between me and patient. So evidence informed practice, Newtonian physics, fascia study, time machine management, no lotion, no action, mobility, stability. These are all the 10 concepts. Each concepts in my workshop, I'll speak for an hour. So all this 10 concept, if you understand, then you can just push into the algorithm mode. Okay, in nutshell, what is KCAT? In nutshell,
1 minute. Sorry
yeah,
to interrupt, sir, but your
yeah,
voice is breaking in between. Sir, could you just check?
yeah, I'll check it out. So, can you hear me now?
Yes.
Hmm? Can you hear me now?
Yes, sir, we can hear you now.
Okay.
It's
So
clear.
in nutshell, what is KCAT means? KCAT is an ultimate aim of this KCAT science is to improve the mobility and the motility. Mobility means movement. Motility means movement for life. Your heart is motile, your lungs is motile, and your peristalsis movement of stomach is motile. Your kidney is motile. Your pancreas is motile. That is called organ movements. So mobility and motility with a feeling of pain-free universe in the sedentary infectious era. So basically, before I used to call sedentary era. Now, because of Corona, I added the word sedentary infectious era without the help of pharma molecules. The ultimate aim of KCAT is to kill the pharma molecules. Without pharma molecules, we want to make pain-free universe. That's all about the idea and mission of this KCAT in a nutshell. So why it is called revolutionary concept? We should understand that KCAT create a strong belief system between practitioner and clients, evidence informed practice. Okay, now you understand the whole world is going behind evidence-based practice. Why I'm just practicing evidence-informed practice? Because there are few strong reasons to create a good balanced relation between you and patient. Before that, I would like to explain you a small story. So in those days, we call it as LIMP. MBBS is called LIMP in 60s and 50s. So during those period, the Vaidya, actually the people who are doing a traditional medicine war, flagging all over the country. So today, how we are just waiting outside for consultants. Those days they will wait for Ved. And once the Ved come and the people will go and just show their body. And those medicines, traditional Indian medicines, take 6 weeks, 3 weeks, 2 weeks. And you have to take the medicine in the cumbersome mode. That means actually morning 6 o'clock you should take empty stomach, and 3 hours you should not eat anything. So this kind of cumbersome world was going on. But one good thing was, those days all the medicines act slowly but permanently. During this time, so the medical practitioners want to just get into the like what how the physiotherapy is now. We want to get into the shoes of medicine. So medicine want to get into the community as a medical people, as a medical science, to make them believe, because the belief system is very important. So during that time, they got a golden a golden magic stick or wand they got, that is called paracetamol. So what they did means, anybody comes for fever, they give paracetamol. So paracetamol will not solve the issue and will not solve the problem if it is an infection or something. But one great thing is, once you give, immediately it shut down the problem of fever, and fever will be reset at the level of thalamus. So the patient feel that feverless. So what happened? Naked eye changes. He will start to observe. So he start to believe slowly into the medicine. So then other medicines came into the market. Slowly the people see, you need a small wand, magic wand, to make the people to believe that actually this can change the things. So that way the paracetamol helped them. So in that sense, what I thought means, we want to create a evidence-informed practice. Patient coming into the clinic and with the neck drop or the pain, not able to move, dysfunction, or patient not able to range more than this, and there is a dysfunction, or patient could not able to walk, he is limping, or patient having a severe pain with radiating nature. When he come into the clinic, I have to treat him. Once he go out, at least few pains he should drop into my clinic and he should go. So that means he can see in his naked eye how much changes he has happened. So that should be recorded in his brain. So this is called evidence-informed practice. Evidence-based practice means, after treating, if I show MRI, before MRI, after MRI, the medical person can understand. Whereas the civilians can't understand, they cannot appreciate it. Whereas evidence-informed practice is, I was not feeling well, now I am feeling well. I cannot able to move freely, now I can able to free fully. Now I can able to have a good freedom of movement in my hand. So all these things will just re-insisted him, and he will just start to self-realize and self-intuition, then he will start to believe the subject of physiotherapy. So I was just wondering for finding out such kind of subject. So I found out this KCAT. So KCAT is an evidence-informed practice. It give a result like that. The patient, once it come in and going out, there is a huge difference you can see. So I said there are different fascias in our body. So majorly I just show a few fascias for your understanding, because we are neglected portion of fascia in our anatomy and physiology. That's why nation level we have to change the syllabuses. We want to revamp the syllabuses based on the advancement. So advancement called the recent trends. So here the fascia is, I just show few example fascia: iliotibial band, thoracolumbar fascia, epicranial fascia, and you have a plantar fascia. So these are all the different kind of fascia in the body. These are all the fascia which you know very well. So that's I gave the example of these fascias. Okay, fascia is not only covering the body as a superficial fascia, there is a deep fascia too. The deep fascia are which is covering the muscles in a different layers. If you take a muscle is actually a combination of muscle fibers. So muscle fiber bundle. So muscle fiber bundle is a combination of muscle fibers, and muscle fibers are the combination of myofibrils. So myofibril is the smallest part which is covered by endomysium, and muscle fiber bundle is covered by perimysium, and muscle is covered by epimysium. So this epimysium, perimysium, endomysium, all these three things are different layers of deepest part of your fascia. So there is a superficial fascia and deeper fascia. Whenever the muscle contract, it is a contraction is between the two facial layers. The facial layers are smooth, soft, and also they have good fluidity and hemodynamics. They start to move smoothly. So muscle will work efficiently. Suppose if there is a small struck in between, so what will happen? It stops. It stops. It stops. So that's a problem with the so the fascia is superficial as well as the deep fascia. Okay, I want to show the fascia signs. I'll say that it is a three-dimensional model. KCAT is a three-dimensional model. So for my, I created the evidence, all the evidence is in sonography. So that's why the Western world can accept my all this old literatures of my all the Siddha, Ayurveda, and all those things. So what is how you can see means basically this is a skin, and below the skin you have a superficial adipose tissue, that is subcutaneous tissue. There's a adipose tissue, and below the adipose tissue you have a superficial fascia, and below the superficial fascia deep adipose tissue, and below the deep adipose tissue you have a deep fascia, endomysium, perimysium, and epimysium, and again you have a muscles. So similarly, if you see in sonography view, so this is basically your skin, and below that these are all the tissues. This is actually adipose tissue, superficial adipose tissue. So this is the line is a superficial fascia and deep adipose tissue. And again you take this is actually a multi-layered structure of deep fascia, and after that you have a muscles. So similarly you can see here the microscopic structure. So microscopically you can study, and macroscopically functionally you can study with the sonography, and you can study with your diagram of 2-dimension. So how difference is 2-dimension with 3-dimension functional and 3-dimension non-functional you see. So basically that's why we need KCAT to understand the each functional and dysfunctional area and 3-dimension participation. So what are the combination of fascia? Fascia is a combination of elastin, collagen, ground substance, and water. These are all the 3-4 things, basic things which is get mixed and which create elastin, collagen, and ground substance and water. All these 4 components combine to form your fascia. And we have a facial connection. One of the facial connection which is evident connection is head to toe. That is basically your plantar fascia and your fascia connecting your Achilles and your hamstring, sacrotuberous ligament. And this is actually a facial connecting chain which is by Tom Mayer, and which is a beautiful surgical, what you can call it as surgical dissection. So I want to just show that there is a real connection is there. That's why sometimes you have a plantar fascia, if you treat, the patient can get out of migraine. Or sometimes when you treat a cervicogenic headache, automatically the plantar fascia get all right. So there is a connection basically. So we have to understand where the connection is, where the force transmission problem is there, and what is the formula we should apply, and what are the principles and concepts we should apply from KCAT, and what is the diagnosis pattern, and how we have to come up with the solutions. Okay, now I'm going to just show you something. Okay. So now I'm going to show you something which is to make you understand easily. So if you want to understand that what is elastin? Elastin means it has to be responsible for physics stress by strain, which is called Hooke's law. So what is Hooke's law means? When I stretch this rubber, it is going back. If I stretch this rubber, it is going back. So when I deform it, it can reform. Deform, reform. This is called elastin. So your fascia is basically elastic nature. Okay. And what is the other part of nature of fascia? Fascia is a collagen nature. Collagen means it's very strong and tough. You take a putty or you take a kind of a clay. So I pull it. It is just, it can go deform, 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 deform. And at one point it get injured, right? So it is having capacity for deform slowly. It required more force to deform, but it will just injure at one part. So perfectly the mixture of both elastin and collagen, and which is just combo with your water. 70% of your body is with water. Even during this COVID season, you want to just keep your virus at the bay. You have to be well hydrated, the water. So water is everywhere, 70% around the body. In Kent purifier also, you can just see that whole body is contained. So the fascia is maximum packing materials in between. A friction-free movement is done by the water. So water, collagen, elastin, and ground substance. So ground substance are basically the substance which is a nourishment giving to the fascia, nutritious substance giving to the fascia. They are ground substance. All these four molecules are just combined to form your fascia. So each fascia, you have a plantar fascia, you have a iliotibial band, you have a tensor fascia lata, you have different fascias, epicranial fascia. All this fascia, the combination is different. In something you have more elastin, something you have a less collagen, somewhere you have a less collagen, you have more elastin. Depends upon the functional requirement of the nature. The collagen and elastin will replace that particular structure. So if you are going to not disuse for a long time, the collagen will be more, the elastin will be less. Suppose you are regularly using more and more and more, so your elastin and collagen will be perfect balance. And you are just stretching too much beyond the limit. So what will happen? Your elasticity will go away, and elastin will be more. The flexibility will be more, whereas the stability won't be much. So that is actually a beauty of this the changes of pattern of collagen and elastin methods of levels. So that's why I say it is a mathematical model, it is a physical model. It is not something like you do this, it will happen. For tennis elbow, what you do? It's not like tennis elbow. It is what is the location, and what is the problem, what is the past history, what is the present condition, what is going to be a future dysfunction, and what is going to be a disease. So it is a titrated value. It is something like what you can call it as like a mathematical model. X plus y is equal to z, and what is how the things will come. Whether first you have to do a addition, then you have to do a subtraction, then you have to do multiplication, then you have to do division, then you will get the final answer. So that's why I said it is a mathematical model. Again, I want to show something that this fascia is working on tensegrity model. What is tensegrity model means? I'm just standing straight. So people believe that I'm standing straight because my framework of the body is managed with the skeletals. But skeletal system, definitely it's a framework, I accept. But the skeletal muscle, skeletal system cannot able to maintain your framework because you cannot do against gravity without any support of facial system. So the facial system have a method called tension plus integration. Due to tension, it got integrated. That's why it's called tensegrity. Suppose, for example, when you are standing, the left and right side will get a proper tension, like a tent. So that's why your pole is standing straight. So suppose one side the tension is less, the other side is more, you get a postural changes, alignment, malalignment. So basically, when you are just adapting the right posture and right thing, it is not because you are adapting or not because of your feedback system is working. That's why I was little against ergonomics, because you cannot consciously put anything. Suppose somebody is asking me, sir, I want to take a good ergonomic advice. So night, how to sleep. If I give some advice to them, you have to sleep like this, I'm a fool, because if you listen to you myself and you are just sleeping in that way, I have to sleep like this, I have to sleep, you cannot sleep because your mind will be there, you cannot sleep, you won't have a peaceful sleep. So basically your body will go for adaptation, depends upon the tensegrity model. So the tension plus integration, the tension results in integration. This is a beautiful toy. Actually, I love this toy, I use in my workshops. So look at here, this actually the sheep is just standing. So what I'm doing means I'm going to cut the fascia. So what will happen? Whole structures has gone. Now I'm going to inflate the fascia. I'm going to create the tension in the fascia. So entire bony system has get adapted to it. So this is basically a tensegrity model. And now I want to explain you how the fascia is. Again, I'm saying the fascia is also a tissue of 3-dimension. So it is 3-dimension, means it works at the multiple level. What you see in the books like that, it is moving in a 2-dimension pattern. It is not moving in 2-dimension pattern, it is moving in a 3-dimension pattern. For example, if you see, I just use, this is a fascia net, you take it. So what I'm doing means, I'm just moving it, I'm opening it, moving it, opening it. So it's working in all direction. See, it works in all direction. It works in all direction. It's not working in 2 dimensions. So fascia is basically a 3-dimension model. That's why KCAT is insisting about 3-dimension model to work out. The last but not least, I want to explain a few things beautifully. You can just penetrate into your deep fascia with some techniques also. So first, let me understand. I will give you some idea. You want to experience a posterior chain. I will just give some idea. You take your both pad of your index finger and just keep it behind your occipital protuberance and just close your eyes. And closed eyes, you try to move your eyeball side to side in a closed eyes. You will start to feel a palpation over here. So this is actually a movement of rectus capitis muscle will just move along with tracking the eyeball. So what is actually happening? Actually what is happening means the eyeball is connected with the posterior chain through the epicranial fascia and it is connected to occipital protuberance. So basically diplopia, double vision, or sometimes a tension headache or migraine, most of the times it is cervicogenic model. That is because of your problem at the occipital protuberance or tightness of epicranial fascia or orbital fascia. So these are all the method how you have to correlate with your clinical subjects. So this is actually one of the evidence how we can understand that how the fascia is live. And one more thing, I'll give you an example that actually you can do it. So keep your hand like this, and you try to rotate on one side and you see what you can able to see and come back to neutral. Again, you rotate on other side and just see what you can able to see. So now I'm going to stimulate my internal fascia. So how I'm going to stimulate my internal fascia? Just say 10 times or 5 times, let us say hold. So I did 5 times. Now I'm rotating myself. I can see more. I can see more. So my flexibility has increased. Nothing I did. I inflated my lung and deflated my lung. Inflated my lung, deflated my lung. So deep fascia of your, so when you are just inflating and deflating internally through the air, it's like a balloon which is moving. So the fascia around the balloon, which is basically a pleura, the deep fascia is connected where it is just working like elasticity. So once 10 time elasticity are done, slowly my thorax mobility has increased. So this is all about KCAT. So in simple way, in nutshell, you want to understand KCAT base. If there is a light, it is an indicator which is called pain. The problem will be somewhere else. The switch will be somewhere else, or never ever the switch will be inside the light because there is a problem of accessibility. So always don't beat around the bush of where the pain is there. Find out the root cause analysis of pain. Don't beat around the bush on the same part of the pain. So that's all about KCAT. So it's a small idea I want to just share with you as an orientation, and that's the just I want to give what I want to say all about. I think it's fruitful for you. It must be useful. Now I can go with the questions if anybody want. I can just go for the answers. So you can ask questions. Any questions? Okay, somebody has asked, somebody is asked, after elasticity, that is called plasticity. Yeah, elasticity is basically a functional area. Plasticity is called regeneration area. So once you cross the elasticity, once you practice elasticity, only you can reach to plasticity. Directly, if you go to plasticity, that is called injury. That's what happened with your stretching, normal stretchings.
So there are 2, 3 questions if you would
Yeah,
like.
you asked Manit because I can't see this. You just
Yes,
asked me.
sir. So the first question was about that what is the difference in KCAT and myofascial release? And then one more interesting question was that does Golgi tendon works in this technique?
Okay. So the problem of actually the Indian science, the indigenous science, I call indigenous science as an inspiration to teach to Western medicine. The difference between Western medicine and indigenous medicine is the Western medicine want to go for uh, accuracy, but actually Indian medicine work for approximation. Number one. Number two, second one is the Indian medicine will have a pharmacognosy effect, whereas the thing is pharmacology effect, molecular effect in English medicine. The problem of the Western and our medicine, you should understand in this KCAT, here we are going to work on as a global work. It is not an individual work because the isolation science, whatever you called cause effect method, which is called evidence based practice. So here we are taking a proper evidence informed practice where we are end up with the difference of functional changes, both naked eye and as well as the tissue level with the sonography, which is a functional changes. Okay. What is the difference between MFR and this? See, MFR is basically a release, myofascial release. They call it as release, but here I'm calling it the word called activation. Activation is different from release. Release means it is actually changing the length to small length to bigger length. But here, activation means in some place I will do a big length, some place I will make a short length also. So here both shortening also I will do and lengthening also I will do. Depends on the requirement, I will do the activation. So here I'm just jaga raha hu usko. I'm just stimulating, I'm educating, I'm just waking up. I'm not making it to relax. I'm just giving a way how to work out, but I'm not making you to passively to work out to understand. I'm teaching to the tissues where to activate, how to activate, and when to activate, which way you have to activate, whether you have to activate in a very fast way or in kind of a isometric way or isokinetic way. So, and once you go through the facial science, basically, sometimes you will start to look back that muscular science is something like palpably we should understand that whether it is fact or not. So that's a problem basically. So here the myofascial release is basically release, but here we use release as a one of the part, but actually it is an activation. So more or less it is an activation part. We can activate internally as well as externally, both activation. Now breathing through that, I'm activating my lungs. Through lungs, I can activate my liver. I can activate my peristalsis. I can activate. So that's why I'm saying it is a Newtonian physics as well as a combination of blended effect of metaphysics.
Thank you, sir. There is Dr. Rishi Jain interested in knowing that how to treat gluteal tendinopathy and piriformis syndrome through this technique.
Okay. So basically, again, we have a 693 muscles in our body. All the 693 muscles, we have a definite way of anatomy of Henry Grace, thanks to him. We used to read that origin, insertion, nerve supply, and function, which is basically our education system has taught us. So that's a very good idea. But according to KCAT, these specific muscles are irrelevant to the problems. The series of muscles which is connected by the tendon and fascia, they all are relevant to the problem. Each muscle we have a face value. If you add the face value, you will understand the outcome measures. Based on the outcome measures, you will correct the muscles. So it is, if you are saying there is a gluteal tendinopathy, okay. What is the function of gluteal muscle? Gluteal muscle either do abduction or extension, okay. So abduction and extension, there is a problem. So there is some problem. This is actually a tendinopathy. Tendinopathy means the tendon has been something, there is anatomical changes has happened pathologically. So tendinopathy, this is an assessment basically. This is actually a two-dimensional assessment. But during functional assessment, we should understand that exactly the tendinopathy is because of that or somebody else is responsible. That's why I said that in KCAT, the input is actually your light is somewhere and problem is somewhere, your switch is somewhere. Exactly, the tendinopathy means I focus on tendinopathy of that particular gluteal muscle. I don't work on gluteal. I may work on the other area. I may work on sacrotuberous ligament. I may work on your calf where the compensation happens. Plantar fascia may compensation happen, or in your epithelial fascia there is a compensation must have happened. So where the compensation happened will, if I just trace through the course, I can find out the dysfunction reason. So that's why I'm saying here, I'm not using the word diagnosis or differential diagnosis. In KCAT, I want to use a typical Indian term called root cause analysis.
Thank you, sir. I think I have to filter a few questions because there are very questions who have common answer. But there is one more interesting question, that can we say that principle of acupressure is based on KCAT?
Yes, I can give some ovation for your acupressure also, because acupressure also is working on both superficial and deep fascia. But again, what is the problem means the acupressure, exactly how much pressure we have to give and what way we have to activate, and whether we are activating to the, see, basically that's why I'm saying it's an oriental medicine. I was not found out anything. It was existing. I'm integrating. I'm practicing. I'm getting results. I'm putting in a paper and I'm just working on it. So that's why it's an oriental. I'm just respecting the oriental medicine as well as the Western medicine, but I want to take out all the break down the myth. So basically, don't underestimate any science. All the science have something beauty in it. So, but all the science, it's very important how to use it, when it use it. So what I made it here means I made it very clearly what to do for what and when to do for what. So that is actually algorithm. So based on that algorithm, we just do it like that. So in that way. So basically, acupuncture, acupressure, the what again, dermatome, myotome, everything I believe, everything is there and everything is true and everything works well. But all this thing you should know the knowledge of application. सारिगमा पदनिसा साथ ही स्वर है, लेकिन उसको ए आर रहमान कैसा यूज करता है, दूसरा कैसा यूज करते हैं, that makes a difference. So application of knowledge here, you don't ask me the question what to do in tennis elbow. So tennis elbow, what you will do, how do you know it is tennis elbow? Because of tennis, somebody using a steer or somebody using bell and doing chapati, for the reason must be different, and the different kind of stress level, different kind of strain level, different kind of repetitive strain level. So all the sports injury is not mandatory you should play sports. So what I'm saying means you should identify the cause. That's why root cause analysis, again, it comes to act and play. So acupuncture, acupressure, all the traditional medicine has a beauty in it, but we are trying to take that beauty and we want to create Western world to understand in the naked eye through sonography evidence.
Yes, sir. I'm not sure how many questions you will be able to take because there are many. Vikas Patel wants to know that fascia is a neural structure, then how it improves movement with eyeball at occiput level.
Okay, see, basically we want to go through anatomy and physiology of, see, basically fascia, we read it as a component, as a chemical component, most of the books. But actually the fascia, you should know there are a lot of free nerve endings in the fascia. The fascia, that's why I have my first principle of KCAT is sensory input is equal to motor output. That is the first point I give. So sensory input is equal to motor output means the fascia can be sensibly stimulated. That's important word. Sensibly stimulated, titratedly stimulated. That's a very important. That is called threshold level of stimulation. So if you threshold beyond, if you stimulate also, fascia doesn't work beautifully. And if you go below the threshold also, it doesn't work beautifully. So you need each fascia character and quality, then you have to work at the threshold level. So that's one. And second one is the fascia is a actually peripheral sensory nerve gate for your all sensory and motor fibers. So that's why it is a first point of contact. So it is again a sensory organ. I always call in KCAT, the fascia is the seventh sensory organ. Among the six sense, seventh sense is fascia. It's one of my slide is there. Seventh sensory organ is fascia.
Yes, sir. Then there is one question from DM Monica, I guess. She wants to know how fascia release help in resolving muscle soreness caused in muscle after heavy workout.
ओके मैं आपको इसको सिंपल आइडिया बताता हूँ. यू टेक एक मसल को लेके एक पैकेट में यू टेक एक टिश्यू and cover it with your what you can call it as with a plastic bag. Now what happened means the plastic bag you rinse the plastic bag. So what will happen, this is a muscle and this is coming slowly screwing and it is just getting struck up. So once it's struck up, the contraction of the muscle, see actually we read the movement of the contraction pump of the muscle is between the actin myosin filament, but beyond the actin myosin filament there is a friction free environment which is created by the fluid, which is basically maintained by endomysium, perimysium, epimysium. If there is a struck in endomysium, perimysium, epimysium during your training process, that is called DOMS, delayed onset of muscle sore. If it happens, what will happen means that will get struck. So that struck, we should not believe that it is happened because of your actin myosin problem. So actin myosin problem is very rare case, whereas most of the times endomysium, perimysium, epimysium get struck. So that's why when you release or when you do the massage or something like that, so the domes get settled down and there the chemical changes happen, the metabolic changes happen, where the lactic acid is going down, whereas the pH low to high change ho jata hai, so you are getting a relief.
Thank you, sir. Then there is a very interesting question from, I guess, Pooja. She wants to know who and when developed KCAT principle.
So again, it is a joke actually. That's why I'm saying this is developed by me.
Exactly.
Because I want to treat my patient in a better way. So I started to treat in that fashion since 10-15 years. So I get results. So I made it as a technique. I got patented this technique. So based on the patent, I submitted even in UK. So I got it for Oxford also, some things for this. So I patented in India also. This is a KCAT is owned by me. It is a indigenous Indian, made in India technique by an Indian, myself.
Thank you, sir. Then there is Jitendra Munjal who wants to know your opinion about the property of fascia, like conversion, gel, solution property of fascia, thixotrophy, and piezoelectric property of fascia.
Okay. See, basically, what is piezoelectric effect? Any pressure will create a deformation of a molecules. So once the deformation resettle its position, it releases some latent energy. So that is nothing but piezoelectric effect. So all the tissues, mostly they live tissues or belongs to your piezoelectric effect, number one. Number two, thixotrophy. Thixotrophy means talking something about viscosity. So basically, your living body is 70% of water. Totally, it depends upon the property of viscosity. So the viscosity is a major area is if you see elasticity and as well as the viscoelasticity we call it. So both are very important, two eyes of your thixotrophy. So basically, when you press, again the molecules position its back, again it come back. So that's nothing but this. This both are working amazingly in fascia, and fascia is relevant to the thixotrophy, viscoelasticity nature. And so that's why I'm saying the training of fascia, you have a threshold level. So the threshold level of training should be taken in a sometime activation, sometime release, sometimes stimulation. There are different things. That's why I'm saying fascia of different nature. IT band have a different fascia, and your thoracolumbar fascia is a different fascia, whereas your epicranial fascia is a different fascia. So each fascia is having a different nature. So learn, you have a different muscle, flat muscle, tubular muscles, each have a different nature. They are made for different function. So similarly, the fascia also made of different structure. It has a different function. So each fascia we can talk for an hour.
Thank you, sir. Then there are two interesting questions. One is about contraindications of CKAT and other is about scope of CKAT in CP.
Okay. First one is contraindication. So contraindication in KCAT is specifically a fresh case of fracture. I don't there is a open fracture, open wound or something like that. You cannot do it. And the second part is the majorly even in oncology, we are just, I'm not taking care. This is a very important steps to stop it. It is not even contraindicated for oncology because again, I'm activating the internal force of your cell. I'm not taking anything from outside. So if you have a metastatic nature, maybe you can consider. And the third point is even for during the organogenesis in first 3 months of prenatal area, so there you should take care. These are all the few things you should take care. And apart from that, it is not time because it's purely you are going to work with nature and you are going to work with the force. The force is always around you. Magnetic force is there, Newton is there, and you have a for any mechanical force is there, and you are going to work on a fluid pressure, and we are going to work on that only. So no contraindication much. Very sensible contraindications are less, very less. And even we use KCAT in the patient in ICU where the head injury patients we are using it. So nothing is the contra. Next question is cerebral palsy. Yeah, it is very effective in cerebral palsy because in cerebral palsy and spasticity, again there is a length tension relationship. So again the KCAT plays a major role on it.
Thank you, sir. I think the last question we have is, uh, she says that we have studied like fascia is just connecting tissue, which is going to deform and reform. So what is the use in activation of it?
Okay. So if you take during this COVID period, the train and truck. It is just a connecting from one place to other place. What is the significance of it? So whole supply chain has stopped. Once the supply chain stopped, everywhere the system get paralyzed. So similarly, that is a beauty of more than this beautiful example. Right now, you can realize that also. So basically, it is a sensible supply chain of your body. The fascia is a sensible supply chain of your body. If there is a supply chain cut down, then automatically the supply will just hamper your entire tissue to get into a pathology.
So many wants to know that is there any book for KCAT?
See, I'm writing this, I'm penning this book for KCAT actually, but I'm just right now I'm taking workshops only KCAT. And the KCAT workshops they can attend. And soon, actually, I'm writing my book. Most probably August or September, I'm releasing my book KCAT. And part 2 KCAT book also I'm just writing. Actually, it's ongoing on process. So soon I will just release the books. But before that, you can just, if you want to learn more about it, you can attend my workshops, which I just do it yearly 5-6 times or 7 times. That depends on my timing and do it. And with that, you can get more idea about it.
So may I interrupt you for a few seconds, sir? Because I think we have Ruchi ma'am with us now. Ruchi ma'am, are you there? Ruchi ma'am, are you there? I just saw you. Hello? Ruchi ma'am? If I can get some help from technical side, please. Ruchi ma'am, are you there?
I think she is not there in the session.
I think I just saw her.
Yeah, just now I saw.
She was there some time back, but right now she is not in the session.
Okay, so do we have some more questions? Sir, there is one very interesting one. When will be the next workshop?
That the lockdown has to decide, God has to decide. I don't know.
Okay. And then there is how can we increase tone in fascia in elderly or post-pregnancy?
You cannot increase the tone of fascia. Tone is something connected with your muscle. The fascia, rather than tone, I can use the word that the fascia ability can be improved. The facial ability can be improved by means of
Actually,
a regular movement, nothing else.
Sir, I'm here.
Yeah.
Thank you, ma'am. Thanks a lot. And let me welcome our very national treasurer, Ruchi ma'am. And friends, you must have all heard the word called women empowerment. but here is the lady who has literally lived that word, and I think for last 5 or 6 years, and what she has done in IAP with the women's and few men's also, that just cannot be done. I haven't seen that being done in any of the other association. Let me please welcome Ruchi ma'am. Ruchi ma'am.
Thank you, Dr. Manit. Thank you, Anna sir. For last 1.5 hours, we are trying to connect you, sir. आपने फेशिया और सारा चेन इतना connected था, उसमें enter नहीं हो पा रहे थे. So, but I could hear everything. So, sir, it was wonderful, sir. Thank you so much to accept the invitation of UP-IPWC team. Sir, the answers I have heard, I think all the participants must have learned a lot. And as Manit said, even I wanted to ask when is the next workshop, so that ये लोग सब और हम लोग सब इसको अच्छे से सीखें. Sir, आप हमेशा बोलते हो कि movement scientist, and I think after listening to this, all the participants, all our organizers must be actually getting the sense why physiotherapists are called movement scientists. And जैसे सर ने बोला ये टेक्निक सर की है, तो physios can do this much. Thank you, Dr. Manit, for being the wonderful moderator. सर झा सर भी 1 घंटा ट्राई कर चुके हैं कनेक्ट करना. I think Zoom is overloaded today, so he's unable to connect. He has sent a message. And thank you, Dr. Anjana, Dr. Renu, for this beautiful concept of bringing Anna sir in our platform. His platform also, actually it is our platform. It is all in the family. So thank you, Dr. Uttara, to be patient. मैं बार बार उसको phone कर रही हूँ connect करने के लिए. Thank you to the technical team. It was streamed live, and everybody has probably we want all the feedbacks from you all. We would like to have more of such kind of webinars and activities. COVID-19 जो है वो जैसे सर ने बोला, we have turned it into an opportunity to learn. We learn as much as giving these platforms, and Dr. Manit and Dr. Renu, Dr. Shruti, Dr. Anjana, entire team of UP State also, Dr. Himandri, Dr. Gaurav, Dr. Santosh, everybody. So all should come together and come up with a big activity and a big workshop of Annamalai sir, so that UP अभी उतना पीछे ना रह जाए किसी भी चीज में. उत्तर प्रदेश अब उत्तम प्रदेश बन जाए. Thank you to all the participants to be patient listener. Thank you for inviting me. Thank you so much. Thank you, Anna sir, once again.
Thank you, Ritu. Thank you so much.
Thank you, ma'am.
Thank you, sir. Thank you. I last word of appreciation for sir was that no wonder now we know that why you have been awarded with Oxford Blue Ribbon as a scientist and Socrates Award from UK. After the hectic question answer round, we all must be knowing that how lucky we were to have you in this session. Thank you, sir. Thanks a lot. And over to IAP Women's Cell, if we can hear.
If anybody wants to say
you as well.
anything.
Dr. Renu Giri, please, or Dr. Anjana Tewatia, anyone?
Thank you so much, Rishi ma'am. Thank you so much, Anna sir, and thank you so much, Manit sir. आपके cooperation के लिए. Thank you so much.
Thank you. Thanks a lot. Thank you, sir.
Thank you so much to everyone.
It was
Thanks
really
for the
a
wonderful.
pleasure to having you here.
Thank you.
Thank you.